The Department of Health and Social Care says it's not trying to replace qualified doctors with physician associates, but doctors across the country are raising the alarm. The DHSC's project to rapidly expand so-called medical associate professions, the largest group of which are termed physician associates, has left many doctors aghast. The plan has been described as one of the most singularly dishonest, duplicitous and downright reckless political responses to the NHS workforce crisis.
When you last went to the doctors, are you sure you saw a GP? If you'd in fact seen a physician associate, would you know how they differ from a doctor?
Unlike doctors who study for up to 7 years, physician associates only require 2 years of study.
In September 2023, there were 3,300 physician associates employed across primary and secondary care in England. In 2015, the number was just 122. A long-term workforce plan for the NHS in England published last year charted a clear upward trajectory in associate roles, setting a goal of 10,000 physician associates by 2036-37.
I think there is confusion about what these staff are doing, because not only are they being labelled as physicians or specialists, but they're clearly undertaking tasks that are inappropriate for their level of training. And that goes to the very heart of the matter, in that no one has defined what these staff can and cannot do. We asked 18,000 doctors what their experience of these medical professionals were, and 87% of them said that they were witnessing practice that was putting patients at risk.
Health Secretary Wes Streeting has made clear he believes PAs do have a role in the NHS.
Where these roles can add value, and why I wouldn't throw the baby out with the bathwater and just say, right, well, let's do away with them, is, we do have a chronic workforce shortage.
Healthcare professionals have pointed out that loading your front line with a huge amount of inexperienced, less qualified people has real safety implications. That's why safety-critical industries don't do it. It's why, for instance, we don't have associate airline pilots.
We have a special report on the growing use of physician associates in hospitals and surgeries and the potential dangers that they may pose.
The British Medical Association has called on the Health Secretary to stop what it calls the dangerous substitution of doctors, and to act urgently on the issue of medical associate professions who are being employed across the NHS without any defined national scope of practice, posing what the BMA says is a real and present risk to patients. More than 13,000 doctors have added their names to a BMA letter warning of the profession's grave concern over the current use of medical associate professions in the NHS. The open letter points to widespread evidence of medical associate professions routinely being substituted for fully trained doctors on hospital rotas, and the worrying trend in general practice funding that has led to physician associates working in practical terms as GPs.
A shocking 84% of locum GPs in England are struggling to find work. A third are being forced out of the NHS entirely, driven out by a cheapening of the medical workforce and the substitution of GPs with alternatives that superficially seem less expensive, but in reality cost lives.
The BMA is calling on politicians to turn this policy disaster around with a proper scope of practice that can reassure patients they are always being seen by the right professional with formally assessed qualifications, skills and expertise for the task. Surely that's a no-brainer. The BMA has announced legal action against the doctors' regulator, the General Medical Council, over the way in which it plans to regulate physician associates. Plans which the union says will mean a dangerous blurring of lines for patients between highly skilled and experienced doctors and assistant roles.
There clearly are concerns, aren't there, with how these PAs are being used.
Alongside the BMA, Anaesthetists United, an independent group of grassroots anaesthetists plans separate but complementary legal action which relates to the lack of any national regulation of scope of practice for physician associates and anaesthesia associates, a vital issue which the GMC has studiously avoided. Again, this should be a no-brainer. It goes to the very heart of patient safety. Here's Richard Marks from Anaesthetists United.
So no national restrictions on what associates can or can't do, no standard guidance on supervision, and no agreed process for patients to give consent. Whose idea was that? Did the GMC come up with it themselves, or was it the government's idea? Where exactly is the GMC getting the money from to pay their lawyers to defend their outrageous position?
A good question. Who is paying the GMC's litigation costs in defending these cases? After all, these cases are being brought to protect patient safety. Surely national rules about what physician associates can and can't do, standard guidance on supervision, and an agreed process for patients to give consent should be a given. The GMC's website says we invoice the Department of Health and Social Care for all costs arising from our work on physician associates and anaesthesia associates. Now that doesn't mean the DHSC is also paying the GMC's litigation costs to defend its absurd position. The website is ambiguous and the GMC has refused to answer a Freedom of Information request on this specific point. So surely now is the time for the Health Secretary to come clean. Is the government underwriting the GMC's legal costs in these cases? Is the government using taxpayers' money to defend cases being brought to protect patient safety at a time when we're told there's a £22 billion black hole in the country's finances that needs to be filled with cuts and likely tax hikes? So over to you, Health Secretary. What's the answer to this question?